cohort at Bellin for the RN to BSN. And one of our projects, I guess, was we did a community clinical, and caring for the agitated patient came to mind when we had cared for a patient that got extremely agitated with multiple admissions back to the unit, and we kept seeing how ill-equipped we were. What's wrong?
I'm trying to think of a patient.
You can't think of the patient?
No, we said we're trying to think of a patient you're talking about.
I can think of two. That I know of.
Yeah, well, one for sure. She was consuming things, went to surgery. Okay.
Well, that's the easiest way to say time as well as things.
So, she was very difficult for us to care for. We saw all the cracks in our care areas that we did not have resources for. So that's where this stems from, and Sarah and I spent a lot of time together on our unit and at Bellin site trying to figure out ways to make it hopefully a little easier, or to at least have some answers to your questions. So that's where this came from. To start out, we want you to just get a number in your mind between 1 and 4, how you feel you are equipped for caring for an agitated patient. So 1 would be not very well equipped, 4 would be I'm a master, I can do this all by myself, I'm really good at this. Do I click?
Just click.
Okay. The objectives, I'm not going to read to you. You can read them yourself. They're fairly straightforward. We go through the escalation of behaviors, how to make an area safe, psychiatric medications we're going to go through, and then what our community resources are. So what are some escalating behaviors? What are you going to see when you're taking care of these patients? And this is interactive. I need you guys to answer. What do you think you're going to see?
More activity.
Huh?
They're more active, more activity.
Hyperactive?
Probably yelling.
Calling out? Calling out? Anybody else?
Probably some could be confused.
Okay, so some things that we got from the Depression and Bipolar Support Alliance was picking or pulling at their skin or clothing, pacing, hand-wringing, unconscious movements, outbursts, shuffling, and clenching of fists. Usually we figure it out when they're fist clenching, and we really don't want to get to that point because they're really jacked up by that point. Some verbal things that you're going to probably hear are, I can't sit still, I feel uncomfortable staying in one place. This is where those walks become very important, just getting them to burn off some of that energy. I need to move around and get out of my room. I know that we hear that a lot. So what can we do? Let me see that. So does anyone know, and I'm going to hurt this word, empathic listening is? Does anybody know what that is?
Don't be judgmental and allow them to verbalize.
Yes. Making sure we also know about our nonverbals that we're sending out. Don't do this. Standing there really listening, being open to what they're saying. It's using empathy while hearing the patient out. And, we have some things listed: not being judgmental, undivided attention, listening carefully, focus on their feelings and the facts, allowing silence. Usually it's like they're silent, okay, we're done, I can move on to my next patient. But we really can't do that. We really need to give these patients the time, because they don't trust people. They're not going to trust you. They have been through so many traumatic things to get to this point that they're not going to build a trusting relationship with us immediately. And restate or paraphrase what they're saying to verify that you're really getting the right message from them. They may be trying to say one thing and you're actually hearing something very different. So So now we're gonna look at this room. So this is a typical room on oneself, and this is a clean room on oneself. What do you think is not safe in this room?
Cords.
Okay, all the cords.
Baby.
IV pole.
The glass
Cool.
Somebody said that.
My favorite thing.
the light fixture.
Anything and everything. So, when we, well, exactly, yes, because they can get from it, just, yeah, I mean, there's a will, there's a way. So any of the cords, the chair not being anchored, you know, we do lock them, so it's harder to move, but when you're agitated and you're angry, you can move that chair very easily. The thermometer, the call light, the bed plug, the canister, O2, because they come in and out of the wall, you know, being hit with any of those objects. The BP cuff, you know, they can strangle you or strangle us, our name badges, you know. Bedside table, over bed light, picture, because the picture they can get glass, the picture, now I see it's a calorie count sign that really shouldn't be there, but that can be a sharp edge, you know, cutting, scratching you, cutting, scratching themselves. So what can we do to help fix that? Even on the other side of the room, there isn't a ton of things that are safe. I've heard of people drinking the hand sanitizer sometimes, so being mindful of that. Drinking the fluid in the sandy wipes, gloves, trying to get into sharps containers, throwing objects, hanging off of here, taking this down. I mean, the hooks, it's everywhere. So we think we're safe when we put a patient on a one-to-one. Oh, we're just gonna watch them. Honestly, we need to make sure that they don't try to take any of these things. And I think it's less stimulating for them too. When we were at the psych center, I mean, it's bare. You got a bed anchored to the floor with maybe a blanket and pillow if you're lucky, because if you're gonna hurt yourself, you're gonna find anything. Their mattresses are weighted, so there was no good way to make a little psych unit on our unit. We just need to be mindful and try and get as many of these items out of the room. So what do? I don't know if you can read this, but this, if you remember the old peritoneal dialysis cards that we had. We're gonna have a card similar to this, if not this, where we can take and get some of that extra stuff out of the room. If we need it, we'll bring it in, use it, and then take it back out. I know this is an extreme situation that we're talking about, but sometimes when these situations arise, it's in the middle of the night, it's on the weekend, it's after 5 on Friday, so you gotta really essentially think on your feet. You don't have the resources there to help you through. Garbages are big. They use the paper bag, or the plastic bags, so what did Bell & Psych uses? Paper bags, just a paper bag on the floor, which when you think of all the bodily fluids that we have, and something we got, which I didn't even think about, was now we have the hampers in the room. That's another thing we need to think about that would probably need to be taken out of the room. Hopefully we don't have to get to any of these extremes, that we can just use our de-escalation and really emphatic listening to the patient and getting the resources there. We just had a situation last night where we needed psychiatry to come see a patient. They were unwilling to see the patient. And then we made a magic phone call and they were there to see the patient. We're hoping that gets better, but if not, you know, we are here to help with that and facilitate that.
And if that does happen, because of course it's gonna happen when the resources aren't available. So I need to know about that because I worked with Charla Bainin and
Dr. Califat.
Yes, thank you, I can never say that.
Dr. Foster.
Yes, so we had a meeting because of it was this patient that we're talking about, We needed to have psych consult, we needed the psychiatrist or somebody to come in and see this patient in the hospital setting. And we've had issues with that in the past, they're just unwilling to come and do that. And Dr. Foster was a great advocate for the providers and for us, saying, we need help. We can't have first of all, they don't feel comfortable. They don't feel comfortable prescribing the psych meds that some of these patients are on and caring for them. They're used to doing their surgery. I mean, that's what they want to focus on. They need assistance. Now, if they get the consult, they come in, they can give recommendations. Foster actually wants them to do the actual prescribing, which is what we're really working through. Dr. Caliphate said that this should not be an issue. So if we do have issues, I need to know about them, because Charlotte Bainin, I mean, she's very adamant that this does happen, and she gave me your cell phone number, so I do have that, and we have some other resources available. So if it happens on the weekend or when I'm not around, Jan, you can contact Jan too. I'll make sure Jan has those numbers. But I need to know about it so we can fix it. So,
Jan, how did you fix it last night? I know you've.
I sent a message to Lori Rexis, Charlotte Bainin,
Okay.
Dr. O, and he was very grateful for the message that I sent. He actually thanked me this morning. It was a very facts-only message. Facts only, no. And he thanked me for the message, because again, these doctors need help.
Yeah.
So
And actually, I sat with the doctor